Hello, and thank you for attending our in-service on the assessment and clinical documentation. First, we're going to start off talking about supervision and coordination of care. Coordination of care begins with referral through discharge and involves the referral source, the patient, nursing, therapy, and aides, equipment and supply companies, and the physician. Supervision of care is overseen by the admitting RN. In cases where we may keep a patient ongoing or a little bit longer term, if there is nursing and aid services in there, then we would supervise them every 14 days, but typically it's every 2 months for all the other scenarios. We're going to talk a lot about the plan of care today, and remembering that the plan of care, or the 45, and a little history on 485, you're going to hear me say both interchangeably. 485 comes from the fact that this was a federal form developed many, many years ago, and any federal or state form has a number. So for this, the plan of care form was the 485th form that the federal government created. So there's where that comes from. So again, developing that care plan in collaboration with the patient, the nurse, and the physician. There's 28 sections within that 485, or often called locators. And we're going to talk specifically about the ones listed here. And remember that it's a patient right that they're involved with and agrees with the plan of care. So we need to document that in our orders as well. The diagnoses, or locators 11 and 13, are related to primary and other diagnoses. So primary diagnoses are typically related to, for our patients, some type of musculoskeletal post-op surgery. And here I use the example of fusion of spine. And then other diagnoses, keep in mind that the patient may have some comorbidities that may exacerbate because of having surgery. So identifying those and assessing for those while you're doing the admission is important as well. Durable medical equipment and supplies, that's locator 14. Some of the things we see are cervical brace, arm slings, wound care, and I suggest you write supplies per section 21 because we spell that out in our orders. We're also going to see mobility devices such as walkers, may see oxygen or other medical devices. Locator 15 is related to safety measures. Remember that most of our patients are fall risk. They're coming out of surgery and they're on narcotics. So that makes them a pretty high fall risk. So please assess those safety features or measures in the home, educate the patient, and make sure that you're documenting. And then locator number 24 or 21, I'm sorry, is the interventions, the treatments that you're going to provide. And remember, on the plan of care, you're writing what to do. And as it relates to your documentation is what you did. So locator 21 are called orders for discipline and treatment. We're going to write our frequency, our discipline and frequency here. So remember, we talked earlier about the scenario where we're planning to see the patient twice a week for 2 weeks, but we want that PRN visit as well. So this is how we would write that. And remember, anytime we write PRN, we're going to write PRN for what? Why are we going to do something PRN? And then in this scenario, if the PT has not completed their evaluation and determined how many visits they need prior to us sending this out, we can just simply write PT eval and treat. And then when we send in the therapy eval, we'll have the order for those frequencies. And now let's talk about your treatment. So this is going to be your typical surgical dressing change. So skilled nurse to change surgical dressing using aseptic technique to anterior neck on the second visit. Remove old dressing, cleanse site with normal saline, and apply a dry, sterile dressing. Report signs and symptoms of infection such as redness, drainage, and odor. So here we have the who, skilled nursing, the what, dressing change, when, second visit, where, anterior neck, how, using aseptic technique, removal, dressing, etc. And remember, in this section, we don't want to forget to include that the patient was involved in and agrees with the plan of care. The next thing is related to assigning goals. So we've got our same scenario for the treatment that we are going to do for the dressing change, but goals should be specific to that treatment. So very simply stated, what goal do you have for that incision while we're in the home? That we want it to remain free from signs and symptoms of infection, such as redness, drainage, and odor. And then maybe we want the patient to verbalize physician reportable symptoms, such as increased pain or signs and symptoms of infection prior to discharge. These two goals relate directly to that incision. And then I included another one on, we frequently pull drains, such as a JP drain. So we've got the orders for that. If less than 5 mLs in 24-hour period, we need to know what the physician's protocol is on that, how to remove that, what to do to the site afterwards, and then how we're going to teach the patient. So our goals related to that is that there won't be any complications while we're pulling that JP drain, and that going back to the same goals as above, that it will remain free from signs and symptoms of infection, and the patient knows when to call the physician. So again, goals are related to the treatment. So let's go back to documentation now. So we have our order here. We've seen that a couple of times. Now, what should the nurse write for compliant documentation? What was done related to what to do? Using aseptic technique, remove dressing from anterior neck, cleanse site with normal saline, and apply dry sterile dressing. Matches the order. But we also want to say what that site looks like. So the incision is 12 centimeters in length, 8 staples in place, no redness, drainage, or odor present, and patient tolerated the procedure without pain, hopefully. Just a few words about quality assurance and performance improvement. So this is a process dedicated to achieving positive results for patients, employees, and the company. How do you support this process? First one is monitoring quality indicators such as incidents, including medication errors, patient employee infections, and grievances, and making sure to communicate these with the office when they're identified. Then we do patient record reviews. So your documentation is a pretty important part of our quality assurance performance improvement. Your employee and file review is also part of this, making sure that you're appropriately credentialed, education and competency upon hire and annually. And also customer satisfaction. And you play a huge role in our customer satisfaction. So remember, if you didn't document it, then it didn't happen. Thank you for attending today's presentation. And if you have any questions, please give us a call.